The temple is a transition zone between the forehead and the cheek area, and it's an area in the face where age-related volume loss can really hollow out the appearance and change the overall upper shape of the face. It's one of the areas where volumetric augmentation to improve the contour is an incredibly effective technique with dermal fillers. What we can see in this patient here is a slight flattening of the temple on the right hand side and a slight hollowing of the temple on the left hand side. This is an ideal candidate for a single point injection technique, which is a safe, effective and reproducible technique for lifting out the upper part of the temple in a patient with mild to moderate volume loss. There are a few areas of concern in this area. Specifically, we're concerned about the position of the arterial blood supply. We have three main arteries in this area. The first one to consider is the superficial temporal artery. This is a terminal branch of the external carotid that branches off just in front of the upper part of the tragus, and it runs superiorly in this direction. Typically, it is close to the hairline and it's easily palpatable. The two other vessels that we are concerned about are the deep temporal arteries. There are two of these arteries. Both of them are branches of the internal maxillary, which runs deep to the zygoma. There is an anterior and a posterior deep temporal artery. The anterior deep temporal artery usually runs in this position. The deep posterior temporal artery tends to run more posteriorly behind the hairline. Now, we know that the superficial temporal artery runs in a close relationship with the superficial temporal fascia, and we know that the deep temporal arteries run deep within the body of the muscle. We know that the position of the deep temporal arteries, even the anterior one, is actually quite posterior to the anterior part of the temple where we will be injecting. And we also know that the deep temporal arteries peter out a couple of centimeters away from the frontotemporal crest. And we know that the superficial temporal artery is palpatable and posterior. Knowing this, if we mark out the frontotemporal crest, this is the bony junction at the edge of the forehead, we can zone off a quadrant superiorly and anteriorly, which is safer to inject. On the basis of this anatomical knowledge, a simple one injection point technique can be devised by drawing a line 1 to 1.5 centimeters posterior along this temporofrontal crest, and then dropping a line 1 to 1.5 centimeters inferior. The tip of that line marks our injection point.